Before I get into the FAMH presentation, I thought I'd share a little bit about myself. I was born and raised in Calgary, Alberta, in this wonderful city a few years ago. I had great parents, great family. I've only kind of realized how dysfunctional it was, you know, over the last couple of years of recovery. But generally, you know, I thought it was a great deal growing up. About 15 years ago, I went to my family physician. And I said basically I was restless, irritable, and discontented. You know, it's a word we use in the 12-step groups. It wasn't exactly what I said, but basically I said, you know, I've done everything right in life. I checked all the boxes that said I should be an acceptable, productive member of society. You know, I went to university. I got a good education. I got a job in the oil patch here in Calgary. It pays well. And for whatever reason, I mean, I was half as happy as I thought I could or would be. I'm making great money. And, you know, I don't know what's going on. And he said, well, you know, you sound depressed. And here's an antidepressant. And, you know, you take that and you'll feel better and life will get better. 5 years later, I ended up smoking crack in a buddy's basement. So my experience with addiction was very different than what I grew up hearing the messages of and in believing. You know, when I went for help throughout that period of time, you know, my family physician wasn't able to help me. ADAC at the time said I wasn't ready. I mean, they asked me, you know, are you ready to stop using or drink? And I said, well, I don't know. Maybe some controlled use would be nice, right? You know, I'm an addict. I really don't want to stop, I think, but I don't think. I mean, I've lost the power of choice, right? So they said, you know, if you're not ready to stop and be abstinent, we can't help you out. You know, the first 12-step group I went to said, well, we can't help you here, so maybe you should go try the other 12-step group. And so, you know, the first treatment center I went to seemed like they were more interested in investigating, you know, their own theories about addiction. And so I never really found the help I needed until I started working with Dr. Hajela. And what happened there is you know, in talking with him, it seemed like he understood what I was experiencing. And he seemed to take the approach that was, I don't know, very different than everybody else that I had talked to, but it just resonated some truth with me. So, I mean, eventually, you know, I got some hope. Over the last couple years, a small group of us started talking about, you know, what we could do to help things go better. And, you know, is there a way we can minimize or eliminate the stigma? I mean, you know, maybe even when I went to my family physician, he says, hey, you got addiction, I probably would have said, whoa, you know, that's not me, that's those people in the street, right? But if we could do more to eliminate or minimize stigma, maybe when I show up, he says, you know, you have addiction, I go, oh, okay, what do I do, right? Instead of the traditional response right now seems to be, oh, that can't be me, I don't want to be one of those bad people. You know, how can we prevent people from progressing to moderate or severe cases of addiction? I mean, when I show up with my family physician, I'm probably in a mild or moderate case of addiction, but what I continue to do over the next 5 years leads to, you know, a severe case of addiction that is much more costly and challenging, you know, to recover from. You know, basically, yeah, how can we get people the help they need sooner? And, you know, if we get help, or if we can convince people to seek help, how do we ensure they have the highest quality help, ensuring that they have the best chance of success? So we came up with this organization called the Foundation for Addiction and Mental Health, FAMH for short. So I'm just going to talk a bit more about the definitions. Raju touched on them. I think it's really important to reinforce them. I want to talk about what the government of Alberta did in 2014. They released a report called the Gap Analysis, showing basically what they think society needs, or what we think we need that we're not getting from the medical community. I want to talk about how FAMH will frame the situation, what we consider the solutions are, and a bit about the FAMH organization structure. So addiction and mental health. You know, my experience has really been with addiction, and why a foundation for addiction and mental health. Addiction is a mental health condition. It's always a primary disease. It is never a secondary disease. And mental health conditions can be both primary and secondary. I'm thinking this is consistent with what you guys heard earlier. I hope so. Other mental health conditions can be present along with addiction. Addiction is often misdiagnosed as other mental health conditions. Treating addiction usually alleviates mental health conditions and symptoms, and addiction can cause other physical health conditions. I'm sorry I broke all the rules of slide presentations, and I have a lot of words. I wish I had more pictures like Elliot. But we're going to do a lot of reading right now, and I think it's important to reinforce some of these things. So addiction is a primary chronic disease of the brain, reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. This was adopted by ASAM in 2011, and I think the key aspects here I've underlined: biological, psychological, social, and spiritual. Is talking about the holistic aspect of the disease. Addiction is characterized by an inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction is often involves cycles of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. There's an easier way of remembering this stuff. It's the ABCDE of addiction. The A is the inability to consistently abstain. B is impairment in behavioral control. C is craving. D is diminished recognition of significant problems with one's behaviors and interpersonal relationships. And E is a dysfunctional emotional response. Recovery. Raju talked about this as well. But I want to emphasize these things. I really do think it's important that we hear these things over and over again as we learn a new way of looking at this situation. So recovery is a process of sustained action that addresses the biological, psychological, social, and spiritual disturbances inherent in addiction. Sustained action. It's something I do on a daily basis. Recovery aims to improve the quality of life by seeking balance and healing in all aspects of health and wellness, while addressing an individual's consistent pursuit of abstinence, impairment in behavior control, dealing with cravings, recognizing problems in one's behaviors and interpersonal relationships, and dealing more effectively with emotional responses. An individual's recovery actions lead to the reversal of negative self-defeating internal processes and behaviors, allowing healing of relationships with self and others. The concepts of acceptance and surrender are also useful in this process. Since some prescribed and non-prescribed medications can interfere with recovery, it would be prudent to consult with an addiction specialist physician in selected cases. Sobriety. A state of sustained abstinence with a clear commitment to an active seeking of balance in biological, psychological, social, and spiritual aspects of an individual's health and wellness that were previously compromised by active addiction. Abstinence. Intentional and consistent restraint from the pathological pursuit of reward and or relief that involves the use of substances and other behaviors. These behaviors may involve, but are not necessarily limited to, gambling, video gaming, spending, compulsive eating, compulsive exercise, and compulsive sexual behaviors. Didn't talk much about drugs or alcohol in there, did it? I talked a lot about the psychological, biological, social, and spiritual manifestations. I talked a lot about pathological pursuit of behaviors or use of substances. To me, that was a big eye-opening experience in terms of addiction related or associated, addiction involving drugs or alcohol. The gap findings. So it says here, to our knowledge, GAP, the first project in Alberta's history that has attempted to produce a detailed, comprehensive, and systematic description of provincially funded addiction and mental health services in relation to population need. So this was a pretty big deal. It's actually about 275-ish pages. And it says here too, we believe that these results should be made widely available and that they provide an important information which to benchmark services, systems, and increasingly important area of health and services. So we believe these results should be made widely available. Has anybody here heard of the gap analysis? Okay, 4 out of, I don't know, 120 or 30-ish. I don't know if that's widely available. I don't know how these things happen, but we hear a lot of other things in this world, but some of the things that we don't need to hear. So I'm just going to highlight, they had, I think it was about 14. I should have put numbers on here, but these are the general findings. Existing services do not provide sufficient care to meet the needs of Alberta adults. Services are mainly operated on a reactive acute care model that requires Albertans to seek care at physician offices and specialty clinics. System resources are heavily invested in providing inpatient, residential, and crisis services. There's a wide variation in costs of providing acute inpatient care for different conditions. System resources are heavily invested in providing care for adults. Programs and services require assistance for continuous improvement. System resources are heavily invested in providing care for mental problems and may be underinvested in addiction services. Support services for people with addiction and mental health problems are not well integrated into addiction and mental health services or general medical services. Neither Alberta Health Services or the Government of Alberta uses standardized nomenclature to define specialty addiction and mental health programs and services. And later on, I mean, two of our panel discussion topics that were most popular were support services and terminology. The GAP findings also generally said 20% of Alberta adults experienced self-reported an addiction or mental health problem in 2012. The government spent $753 million on mental health and addiction program services. So some interesting numbers, I guess. This is how FAMH would like to frame this challenge for us. So in this chart, we have this green line here. On the bottom we have age, and you know, yeah, I'm an engineer, kind of business background, and everything that goes up and to the right is a good thing, so that's why it goes up and to the right. No special reason for that, but the green line represents optimum human health for any individual. And the purple line is this line here. And it represents what we, most of us consider alcoholics or addicts, and it's what we're going to call severe addiction. And basically this results, or can result in premature death. The dashed purple line represents, you know, the life path that can be achieved if we enter into a process of recovery and do things on a daily basis. So we can see we can come back relatively well, or relatively close to this optimum health line. The red line here is what we're going to call moderate addiction. That 20% that the gap analysis talks about, we're going to talk about that being the severe addiction down here in this purple category. So this red category is a moderate case of addiction, and these symptoms aren't usually as obvious to the general public. We don't, you know, we don't look at each other and go, "Oh, he needs help right now. Look at how bad they are," you know. These are the types of things that probably lead to physical health conditions later in life. And that's why we show this line coming off. I mean, the quality of a person's life here isn't catastrophic, but it's not optimum. And they usually end up costing us a little bit as a society in terms of dealing with their physical health treatment conditions down the road. Again, if they engage in a process of recovery, we can avoid a lot of this stuff early on in life. This yellow line here is a person with mild addiction. And again, these people might not actually have significant physical problems, but they might not be living up to their true potential. This one's a little bit harder to talk about, but what I like to think of, it's what we normally call, it's just human nature. You know, when we get frustrated with things or something like, oh, well, they're only human, they're only this, they're only that. And that's kind of the symptoms that we see around there. It's not the ideal world, it's just a little bit less than. And so that's, you know, human nature rooted in addiction. So this graph here is highlighting the connections, or this table is highlighting the connections between the physical health condition and the likely addiction-related cause. So, you know, chronic pain, tobacco, food, opioids, neurological disorders, cocaine, ecstasy, crystal meth, liver disease, alcohol, pharmaceuticals, lung disease, tobacco, marijuana, cocaine, kidney disease, you know. So there's a lot of root causes, even though these people might not be using these substances in a severe way or in the old definitions in a dependent way or an abusive way. It's still contributing to some physical health problems that start showing up later in life. When we go through and we look at the numbers, we see chronic pain. It's a variable scale. The number wasn't be able to pinpoint, so these statistics were a little bit difficult to put together. Sometimes I had to prorate national statistics to the province of Alberta, and so this is the amount of people that would be affected in the province of Alberta based on national statistics. So neurological disorders make up about 10%, liver disease, lung disease, kidney disease, diabetes. I mean, I think these are things that are actual easy and obvious for us as individuals to see a link to addiction, right? I mean, lung cancer is the #1 cancer out there. What's the primary cause of that? Yeah, thank you, smoking. So if we do some simple math on this and we say 50% of these conditions are actually rooted in addiction, that's another 1.2 million people in this province, or another 30% of our province. So now when we go back to our graph here, 50% of our population has some form of addiction that's going untreated at this point in time. So FAMH has a solution, or we have what we think is a solution. And primarily it starts out with prevention and early assessment. If we can do these things and we can catch things sooner, we can avoid a lot of things down the road. If we do have to go to treatment, it's going to be holistic, it's going to be biopsycho. I've put in emotional there because, well, partly I don't understand psychology and sociology and stuff, and just an emotional well-being has been really important to me in recovery, so I understand it fits under psycho. Social and spiritual. In our treatment matrix, we have 15 specific activities, and there is a high degree of cooperation between professional and non-professional services. I know the professional services alone can't do it, and I know the non-professional services don't have the expertise to always do it. It's an intensive outpatient type model. We don't necessarily think it's a great idea to put people in this wonderfully protected environment and ask them to grow nicely and then take them and put them in a toxic environment. We need to teach them how to live in the world that we actually live in. We need to teach them how to accept life on life's terms. You know, it's a 5-year program for severe addiction and 3 years for moderate addiction and continuing care. This is our matrix for treatment. On the top, we got mild, moderate, and severe. I've quantified things because I'm an engineer, I guess, and I like to quantify things. But sometimes we like to compare ourselves as human beings too, and it's like, oh, I'm not that bad. I mean, I'm not that bad. I have a severe case, but I'm not as bad as that guy. Okay, we'll make you an 8 instead of a 9. You know, your treatment protocol is still the same. You still need to do, you know, a lot of work. You still need to make a lot of life changes. But you know, I think the scale is just a little bit helpful in delineating some specifics. You know, over the last month or two, I've talked with a lot of the people in the Calgary Homeless Foundation and that sector. And I mean, these people are up around probably a level 10 in severe addiction, right? And you know, just in the last 24 hours in talking with Elliot, I mean, I've really appreciated the medical aspect and you know, the desire, the opportunity to maybe help people out that might not be able to achieve abstinence. Maybe we can find something to help them deal with that. So yeah, 15 activities. It's fairly intensive. The M stands for it should begin immediately. The D is the activity could be deferred. And I mean, when you're looking at food, you know, if somebody's malnourished or something, we're not going to worry about what they're eating. But I mean, if they have an issue with food or addiction associated with food, well, then we need to address that immediately. These are 28 initiatives we brainstormed over the last couple of years. I'm not going to get into all of them because it's not possible to do everything at once. But basically, these initiatives actually seem to be fairly in line with the gap analysis. We're going to focus on 3. The first one being the cooperation with the primary care physicians. So, reason being, it's a sweet spot. 30% of our population is likely affected by this. I mean, we need to do some work around that, and we need to fine-tune our understanding there. But at first glance, it looks like it's the sweet spot in terms of dealing with a large number of the population and hopefully preventing some physical problems down the road. And again, that's around prevention and early assessment. Working with the homeless sector, you know, they have an established system that's in line with our outpatient treatment model. And our desire, one of our other initiatives is an addiction database or a registry to help us, the medical community, deal with addicts a little bit better. And then some public awareness campaigns, mental hygiene, cage assessment, and low-risk drinking. So that cooperation with PCs, primary care physicians, will basically involve some training of FAMH volunteers, training of the primary care physicians, and assigning the volunteers to the primary care clinics. And basically we want to set up a situation so that somebody comes in like myself and says, hey, I'm restless, irritable, and discontented, and I probably don't say it that way because I'm not that clear at the time, but the family physician will be able to recognize that, hey, this person is likely has a problem with addiction. Would you like to sit down with somebody that has a similar situation and similar experience and background and just talk to them a bit about it? So hopefully they agree, and the FAMH volunteer can come into the family clinic and meet with them in that professional environment, and they can talk a bit about the situation, and they can decide, would you like a comprehensive assessment? Would you like to see an addiction and mental health specialist? Or would you just like to actually, come with me to some of the peer support groups that are available? So we'll look and see how we can, work together to help people get the treatment they need sooner. And we also think that, given the nature of the healthcare system as it is, we think it would be helpful to have FAMH volunteers help with that burden, and hopefully they have that experience. I mean, that's the model that's worked well in the 12-step programs, is that ability to identify and give some hope, so that the professional person sometimes can appear a bit like a hypocrite, and you're not, okay, he's calling me out, but this person that's actually been through it might actually be able to better connect with these individuals, especially with the stigma that we have today still. The cooperation with the homeless sector, what an amazing job I think the homeless sector has been doing. They could do more, but in the last 5 years, I mean, they've come up with the HIMS system, the SPDAT rating. On a weekly basis, they meet as a group. It's called the Coordinated Assessment and Assignment Triage, and they look at high acuity, mid acuity, family and youth, and their individual agencies sit around the table, and through the HIMS system, they have a log of all the homeless people, in the city of Calgary, and where they have intersected the system for treatment, and whether or not we can get them, in the specific agency for what they need. And so, I mean, I was really impressed with the high level of cooperation and where it's come from. What I felt was wanting in that situation was the lack of treatment for addiction. And that's a little bit confusing. I mean, the statistic I found is that 35 to 75% of homeless people suffer from addiction or other mental conditions. But, most people, when you talk to them one-on-one, say, no, it's way higher than that. And I think it is maybe how we understand it. I mean, when we're looking at a SPDAT for an individual person and they had their substance abuse rating and it's 0 to 4, she's only smoked crack in the last week or the last month, so we gave her a 2 out of 4. I'm thinking if you're smoking crack, it's 4 out of 4. you know. Maybe if you've only drank alcohol once or twice in the last year, we might bring that down. But, you know, the substances that are used on the street, I think, puts you into that 4 out of 4 category, and I think that's why that statistic gets a little bit confusing. The other priority for the Calgary Homeless Foundation and the associate agents is the Housing First initiative. So addiction and I think some of the treatment around it, or some of our understanding around it, made it confusing to incorporate into this process, because most, as we talked about earlier, most people talk about an abstinence-based recovery program. These people might have a tough time achieving abstinence, you know, unless Elliot comes up with something we can use. And so it's been hard for people, I think, to embrace helping these people out. And, you know, just because they're not able to achieve abstinence doesn't mean that they need to be refused treatment. So, you know, I'm hoping we can go further and start working with some of the existing agencies to help develop, you know, treatment-specific programs for the individual agencies. And then a public awareness campaign. The first one we think is most important is mental hygiene. You know, it's totally socially acceptable to practice dental hygiene, to brush my teeth and floss on a regular basis. Why not mental hygiene? You know, mental health isn't a permanent state. Life changes happen all the time. You know, we go to the dentist, you know, once a month or once a year. We get the full-on, you know, assessment, X-ray, everything. Things change with our dental hygiene, right? What about our mental hygiene? Like, if we went through some major life changes, I got married last year, I got a new job actually starting, you know, so a lot of things happen in life. What is my mental state? What am I doing to check that with, you know, professionals, right? So, and I think Raju talked a bit about this too, about how we all need recovery, or we're going to say mental hygiene. I don't know what the right word to use is, but I would like to know what we do on a regular basis to brush our brain. You know, we're going to suggest meditation, sleep hygiene, regular exercise, healthy diet, and definitely an annual checkup with a qualified mental health care provider. Why not? Why not pop in and say, hey, how am I doing? What's going on? Is there anything going on? Should I come back in 2 weeks, or maybe I'm good for another year? You know, what are we doing on a regular basis to make sure we are of sound mind? The CAGE assessment. So this will have to help feed into that PCN network. So if we're out there doing a public awareness campaign and we're talking about this CAGE assessment, which is how we can identify, you know, have we had a tough time cutting down? And originally this was around alcohol. But have we had a tough time cutting down on alcohol, drugs, some behaviors? Are we annoyed when our partner or people close to us in our life want to talk about that thing that we have a tough time cutting down on? You know, do we have guilty feelings secretly that we haven't shared with anybody? And, you know, the eye opener. You know, do I wake up in the morning and the first thing I do is reach for my cell phone to see who called me? You know, who might be in touch with me today, who is thinking about me or something like that. So these are things that we want to broadcast out there and share with people. And these are the indications that if you're answering yes to any one of these things, that's maybe one you want to do. Go visit your healthcare provider, your family physician, and say, hey, you know, maybe I need to talk to somebody a bit more about this. And then there's the low-risk drinking. And there's already been some good work done on this stuff. So the Canadian Centre on Substance Abuse has a 2-page guide online, and that's based on the you know, Centre for Addiction and Mental Health guidelines. That's 10 drinks a week, no more than 2 per day for women, and 5 drinks a week, no more than 3 per day. The important thing in here to remember, as Raju reminded me when we were going through this, is these are for non-addicts. Okay? So it's not for us addicts to go, okay, if I can, you know, yeah. But the challenge is this really isn't well understood or well shared, I think, throughout our society, and it's not something we don't want to do. We don't want to recreate the wheel here. We just want to do a better job sharing this with the general public. And I mean, if you're having a tough time, you know, with low risk drinking in your life, maybe you have a problem and you should come see your family physician. So who is FAMH? We're a grassroots, community-based organization, charitable now. Actually, we got our charitable status with CRA last November. We're committed to sharing the realities about addiction and mental health, the potential links between addiction and other secondary health conditions, and the continuing care required for long-term recovery. Our vision is a world where addiction and mental health problems are accepted as health conditions without stigma, where long-term recovery and continuing care framework and mutual support is available for all. Our values are prevention and early assessment, promotion of the highest quality services for treatment, promotion of cooperation between professional and non-professional services, and application of leading-edge research based on society's needs. So bringing people like Elliot and Raju to more people's attention. Our organizational structure, we built our bylaws basically in line with the MUTARC guidelines. Alberta has a really good base of non-profits that go way back, and MUTARD came up with some guidelines and to help us write bylaws around societies. You know, we put together job descriptions. Anyway, they have a great volume of information. So we used that to help us draft our bylaws, and we made sure that we stayed within the spirit and intent of the Societies Act, and that we have a society that represents the population. We do have a membership fee, and the important thing here is under the Act, they talk about membership, and you want to sell membership fees because basically you're demonstrating to the governing bodies that there is general support for the cause that you're representing. And so an important aspect of the membership is that you elect the 3 directors each year for 3 years. So there's 9 directors in the organization. And they will all be elected by the membership instead of appointed by the people that put the most money into the organization, which, you know, has its advantages and disadvantages. But our intention is to be grassroots and representative of society. And every year, too, the members will select the chairperson of the organization. So we want to keep this. It's a little bit altruistic and such, but we want to stay in line with the spirit and intent of a true society in this province. So the FAMH difference, in summary, you know, framing of the situation is based on the ASAM definition of addiction, and we've moved a long way from, you know, the World Health Organization and the DSM, and we think that our framing of the situation is firmly rooted in an accurate, broad definition of addiction that ASAM came up with. Prevention and early assessment is a very high priority for us. I mean, ultimately, we don't want people to end up in treatment. And if they do, well, we have an intensive, holistic outpatient program model. Again, you know, it's real world versus the protected artificial environment. 15 interdependent activities targeting bio, psycho, social, emotional, spiritual dimensions, and it's long-term, minimum 5 years. So I think that's it for FAMH.